wonderful and volunteered to be allow me to do an assessment on him today. So I'll have him come over and then just remove just one shoe and one sock. So when you're doing your physical assessment, and I'm going to take about 10 minutes to do this assessment, just be patient. It's going to take you 8 hours that first week, and you're still going to find out, oh, I forgot to do this or that. It does. It takes a long time, but each week you will get better at it, more proficient at it, until you're able to do it in a nice, smooth fashion. Prior to even doing the physical assessment, you have already done your nursing history. So a lot of things you've already assessed. You've assessed his cognitive ability. You may have assessed the way he moves in the bed, his mobility issue, if he walked and got up to the bathroom. And that's a good thing to do prior to a physical assessment, because especially when you do the abdomen, that's when you're pressing down on it, sometimes that's uncomfortable. So you have got some pieces of your assessment already completed by just doing the nursing history. You have seen some facial movements when he's talking, is things symmetrical, all those things you've already included, so you don't have to redo anything you've seen. If he's moving his neck when you see him, some people move in or come into the room, you know he's already got good neck mobility. So you don't have to ask him, can you go right to left, things like that. You've seen it already. Okay. The other thing you want to do prior to a physical assessment is vital signs. So you have a baseline of that, so you know any abnormalities going that way. If he's got a temperature, he's got low blood pressure, very high blood pressure, so that'll clue you into some concerns or the things that are normal. I'm going to show you a head-to-toe assessment, meaning I'm going to start at the head and go back down to the toe. There is no right, wrong way of which pattern and what do you assess first. There really is, and I think in learning, go to head to toe, because that's the way you'll remember everything and you won't forget anything. But as you go on in these couple years, you'll realize, well, I'm on a floor that's cardiac based, and the nurses always do cardiac first and thorax and then maybe abdomen, and that's great, and that's probably what you'll learn to do. When you go to OB in a spring semester, you're going to learn to do breast and GU first and then everything else. So you will adapt. There really is no right or wrong way as long as you cover everything and you properly thoroughly assess all body systems. Okay. So, all right, and of course you introduce yourself. I'm Lisa Round. I'm going to do an assessment on you this morning. How are you feeling? Good. And I'm going to have you just remove your glasses and put them over. I'll take them for you, so make sure I don't. And when doing the head assessment, or you're going to come in contact with any secretions, when I do the eye assessment, you do wear gloves. So, put those on. And I'm just going to touch your head here and feel your hair. Remember the head, I'm looking at the symmetry of the head, so it looks symmetrical. There's no obvious abnormalities. I'm going to look in the hairline, make sure I get to the back of the head and all around, and his hair is fine, smooth. Okay, the scalp is smooth without any type of lesions. I'm also looking for moles or any type of sores, things like that, and that all looks good. I've already looked at his face symmetry. That is all normal. Right side equals left side. And then I'm going to move on down to the rest of his face. So this is a good time to do the temporal pulses. I can feel them. And then I'm going to go ahead and do the eye assessment. Could I have you look up at the ceiling? I'm going to look at the conjunctiva. It's pink. I also noted that the sclera was white with a little bit of red streaks. Now, I find it more comfortable to take my gloves off, and you go on and off with the gloves throughout the assessment. It's up to you. Then I'm going to go ahead and do my eye assessment. I'm probably going to darken the room a little bit at this point because it's easier to see. I'm going to have you look straight ahead. Okay. And it's hard to see in a bright room. And this light is not very strong. Okay. His pupils react equally and constricted pretty briskly. And then could you look at this? And I'm going to bring this closer. There you go. And he had accommodation. So I know I can document Perla when I get to documenting, all right? I also noted when I shined the light in there that the cornea was clear. Now, you may forget to do that and have to shine it in again, but you'll get to a point where you only have to shine the light in once. Okay. Then I'm gonna go on from the eyes, I go on to the nose, and I'm just gonna palpate around the maxillary sciences and the frontal. Any pain here?
No.
Okay. And then I can see that his nose is symmetrical. I'm gonna ask him and check for patency. Could you occlude one nostril and breathe in and out? And do it on the other side. Any obstruction at all?
No.
Okay, very good. All right. Then I'm gonna move on down to the ears, and I can see that they're symmetrical. I'm gonna take a brief look into the ears and to see if there's any unusual wax or any unusual drainage. I know they're even with the outer canthus of the eye. And then I'm just gonna palpate around the mastoid area. Any tenderness here?
No.
Okay. All right, so now I know I can move on down to the mouth area, and I'm going to just shine a light and briefly, and this of course is not working. There it is. All right, open your mouth and stick out your tongue, light left to right. Okay, and go ah. Okay, so when he does that, you can see the back, and you want to see if there's any tonsils. The whole area looked pink. I didn't see any type of lesions at all, no swelling. The tongue was pink, no coating on there at all. And what I'm going to do is have you just go like this with your teeth. Good dentition. Okay, so it's just a brief assessment of the mouth there. Now I can move on down to the neck area. I can see that he's able to hold his neck up. It's in position. Okay, if I have a client, maybe you'll get to the nursing home that cannot sit up, so you note that, and he's not able to hold his neck up. I can see that the neck is symmetrical. There's not any obvious abnormalities, and I'm going to check the midline or the trachea to make sure it's midline. And I see that it is, and then I'm also going to check the pulses, carotid pulse. Good one. Remember, you're only checking that one at a time. And that's good. Nice strong pulses there. So I've already done the temporal, and I've already done the carotid. And now I'm going to move on to the lymph node assessment. So you go right before the ears here, right behind the ears, occipital, and then along the jawline. Light palpation in a circular motion, right under the chin. And then remember, there's 2 rows. And right along the clavicle. Okay. Now I noted that all the lymph nodes were non-palpable, and that's how I would document that. Can you move your neck from right to left and chin on your chest? Okay. Good neck mobility, and he can do that by himself. I don't have to do that or assist him with that. So now I'm going to move down to the chest area, and the best way to do this is have him lie in bed. I'm just going to bring your head up a little bit. Doesn't matter, bring the whole bed up a little bit. Make sure you always work at a comfortable position.
You're stuck on the one. It's gonna fall over.
Oh. Yeah, thank you. It happened on Wednesday too. Okay. Now I'm going to go ahead and do my thorax assessment and my cardiac assessment. Whichever I decide to do first, doesn't matter. So I'm going to start just cardiac. Make sure that my stethoscope is positioned properly and on so I can hear it. And I know from the cardiac assessment, we're going to do aortic, pulmonic, herbs, tricuspid, mitral. Okay, so aortic is on the right side. It's the only one on the right side, second intercostal space. So I'm going to feel where the sternal angle is. It's right here. I can feel the little hump. And this is the second intercostal space. I'm going to listen. Okay. I heard the aortic. Now I'm going over to the pulmonic. Herbs. Tricuspid. Mitral. And this is where I'd get my apical rate. I listen for it here, and then I'll do the PMI, point of maximal impulse. that's palpable. Now, how I would document is that his apical rate is regular, and I can hear S2 best in the aortic and pulmonic area, and S1 best in the mitral area, and that would be my documentation with a regular heartbeat. And then, of course, the number I get as far as the apical rate. I also remember, now I'm doing it over close, but remember, you're always going to do this and place the stethoscope right on the skin. Okay. Now I'm going to go ahead and do the thorax and the lungs, and I'm going to do the lung assessment. I'm going to have you take nice deep breaths in and out, and I'll let you know. Remember, you're going to go right below the clavicle. For the first one, can you take a breath in and out? Compare sides. Can you do it again? Good. Again. One more time. Again. All lung fields are clear, and while I'm doing this, I'm also assessing the thorax shape. I'm looking at the costal angle because I will be able to see, because his gown would be removed, and I could see the costal angle, I could see the sloping of the rib cage. So until I get to the posterior side, I'm thinking he has a normal thorax and normal thorax shape, which is elliptical. Instead of moving him, what I'm going to do is abdomen and then keep the posterior lung assessment to the last, just so I minimally move him. So I'm going to go ahead and do the abdomen assessment. Right now, I'm just looking at the abdomen. Your first thing is the visual look, and that is flat. And then I'm going to go ahead first do bowel sounds before I do palpation. Okay. You know the belly button is the belly button is your dividing factor for the quadrants. So you divide it horizontally, you divide it vertical. So that's upper, upper, lower, lower. Okay. I listen to all 4 quadrants, and I listen up to 5 minutes if I'm going to record an absent vowel sound. Okay, you have to listen for 5 minutes to say absent. All 4 quadrants are normal active. He's got good vowel sounds. And what I'm going to do is just lightly palpate the area. You let me know if you have any tenderness. Hands over, one hand over the other one, or some people do this. Both are fine. But it's light palpation. You're not going to do any deep palpation. Do you have any discomfort?
No.
Okay. And then I'm also going to look at his face every once in a while because he may say no. But he would go, ooh. Yeah. Exactly. But it's fine. I don't have any pain. Okay, so then I could also say palpation, no tenderness at all to palpation. All right, then from there I'm going to move on and do the femoral pulses. I won't do it on him, but remember you do it. It's easiest to do one at a time, and then you probably have to go over the other side. You can do it on the same side, and then palpate real deep into the groin area. Okay, see how strong they are. Okay, then you move on down, and you're checking his legs, and when you do that, you're noting the color. Are there any lesions, any varicosities, sores, anything you're noticing? You're also noticing the temperature of the legs, okay? And you can do a light palpation. Do you feel that?
Yes.
Okay. And especially with your elderly clients or your clients with peripheral vascular disease, diabetes, they may not feel that light palpation. So if they don't, then make it a little bit deeper and see where they do as far as what they feel as far as sensation. You're also noting the hair on the legs. Is there any? Elderly will be very sparse or maybe absent. That's a very normal aging thing. But if you have a young client with no hair, then obviously maybe there's a problem, a medical problem. So you can tell a lot just by looking at the skin and hair distribution. Okay, so then you move down and you're touching. Then also I'm noting any swelling, especially in the calf area. I'm looking for any redness or unusual swelling where one leg is swollen and the other one isn't. If I do note swelling, then I'm going to assess for pitting edema. So you just press down, and if it stays down, it's pitting edema. And if it takes a while to come back, then you know it is. And we don't get too much involved with grading of pitting edema because it's a little harder at this time. So as long as you can pick up edema or not. And of course, his legs are fine. And you always compare size. And now I'm going to go ahead and move down to the pedal pulses. So I can do the first pulse is right here, what we call the dorsalis pedis, between the big toe and the second toe. Palpate it. And of course, then I'm going to go to the other side once I palpate that. It's got a good strong pulse. And then I'm going to go to the posterior tibial. And if I do that one first and that one, either way, it's fine. While I'm doing that, I'm looking at the color of his toes. You can tell a lot from a client, especially your elderly clients are going to have those very thick toes. There may be a fungal infection going on. So you just, and especially with diabetic clients, you can see the condition of their toes. It will tell you a lot, okay? And you're looking at color. The other thing is we're checking for cap refill, toes and fingers. So if you have a client that has real thick toenails and you really couldn't assess capillary refill, just go to the top of the toe, blanch, and you see the quick return. So that's another way to assess if you can't do the toes. Okay. So if this is a client that couldn't get out of bed, this is the time I would assess for his leg strength, lower leg strength. So what I would do here is put on gloves. If he got out of bed, then I know he's got good leg strength. And I'm also assessing his gait, obviously, and looking to see if that is a steady gait or an unsteady gait. Anytime they need assisted devices like walkers or anything, or they need to hold on, it's an unsteady gait. Okay. Could you press down at the bottom of my feet? Okay. And then the other way to do it is resistance.